Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Amira binti Musa. My ID number is 9408030355740001. I'm from Bachelor of Medical and Health Science, Campus OUM Alusta. Okay, today for topic clinical practice trauma and emergency care, I want to present and share with you about pneumothorax. Okay, first of all, I want to share that my clinical practice area are at Emergency and Trauma Department, Hospital Bukit Mertajam. The period is 2 weeks, which is 16 November until 29 November 2020. Okay, first of all, before that, I want to share with you what is pneumothorax. Okay, pneumothorax is an abnormal collection of air in the pleural space between the lung and the chest wall. Okay, according to Papagiannis et al. 2015, said that pneumothorax is an irregular collection of air and gas within the pleural space that separate the lung from the chest wall. There are large, unusual concentration of liquid, which is more than 100, is a fluid built up in the space that may interfere with the typical breathing. Okay, what is mechanism of pneumothorax? First, sudden chest compression that increase the alveolar pressure and it may occur the alveolus rupture. Air that come out in the interstitial area by dissection towards the vesical pleural or mediastinum result in pneumothorax or mediastinal emphysema. Okay, second, increase of pressure in the tracheobronchial tree in the face when the glottis is closed has the impact on the increase of pressure, especially in the level of the bifurcation of trachea or bronchial tree where lobar bronchi separate due to the rupture of the trachea or bronchi may occur. Okay, now I want to share with you what is the cause of pneumothorax. Cause of the pneumothorax is first we call primary pneumothorax, which is no underlying lung disease. Example, smoker. Second, secondary pneumothorax, which is a complication of lung disease. Example, asthma, COPD, and cystic fibrosis. And third, traumatic pneumothorax. Example, fall or any traumatic event such as assaulted motor vehicle accident. Okay, in pneumothorax, there are a few symptoms can we detect to patients such as first, shortness of breath. Okay, chest pain, which may be more severe on the side that chest. Okay, sharping pain when inhaling. And then pressure in the chest that get worse over time. Increased heart rate, rapid breathing, patient will complain dizziness and look confused. And lastly, patient may loss of consciousness. Okay, here you can see there are three lungs. Okay, there are difference between pneumothorax, hemothorax, and hemopneumothorax. According to Kimet et al. 2018, the difference is firstly we know pneumothorax. Pneumothorax is contain air. Hemothorax is contain blood. And hemopneumothorax that means that contain blood and air. Two items, blood and air. Okay, now I want to show you my case presentation at emergency department. Okay, first of all, my case is a male, 45 years old, brought by pre-hospital care to emergency department, which is, I remember, this is an ambulance call. Okay, patient, alleged motor vehicle accident, which is motorcycle versus car. patient are motorbike rider. On arrival or in emergency department, Glasgow Coma Scale, or we know as GCS, is EI 4, verbal 4, motor 5, and total is 13/15. Patient complain of shortness breath and severe pain over left chest. Patient unable to walk and patient also has loss of consciousness. Okay, here is a demographic data about my patient, which is I named my patient as Mr. K. Okay, age is 45 years old, male, Malay, and married person. Mr. K also worked as operator at Electronic and complained of shortness of breath or SOB. Okay, for your information, there are some general health history for Mr. K. Firstly, Mr. K known case of diabetes mellitus and on treatment. Mr. K no surgical history and he has allergies to seafoods. And social history are he is non-smoker, non-alcoholic or non-substances abuse. Okay, now I want to share with you what are the assessments and investigation that we do to Mr. K in emergency department. Okay, first of all, assessment in airway and cervical spine. First, we remove all the foreign body that can block the airway, such as any secretion like blood or any foreign body. After that, we do C-spine immobilization, which is in C-spine immobilization, we put cervical collar on Mr. K and we observe neurological such as numbness or unable to walk or any neurological. Okay. After that, we do assessment in breathing, which is in breathing we look for inspection, palpitation, percussion, and auscultation at the chest. Okay, what we see is inspection. We see reduced chest rise at the left side. Okay, in palpation, chest spring is negative. In percussion, we found that hyperresonance at the upper lower lobe, and in auscultation, we find reduced air entry at the left side. After that, we do assessment in circulation, which is in circulation we are checking for pulse rate, skin color, capillary time refill, and blood pressure. This can help to monitor the sign and the early sign of shock by doing circulation. Okay, here are the vital signs of patient, which is his blood pressure is 144/89, pulse is 101, respiration rate is 24, temperature 36.8, oxygen is 89 under room air. After that, we give high flow mask, it increased to 95, and then rare flow is 87. Assessment at abdomen. Okay, we found that abdomen Mr. K soft, non-tenderness, no scar or wound. We also do assessment at pelvic, that we find that pelvic spring negative, no wound and no obvious bleeding or no deformity. Okay, we do assessment for upper limb, which if we found that there are 2 cm laceration wound over right hand, multiple abrasion wound over right and left hand, and patients still able to move to who and up their hand. Okay, and then we do assessment for lower limb. We found that abrasion over left knee, but patient complain unable to move the leg. Okay, we also do assessment for posterior body. In posterior body, we do lock and roll, and we find that no step deformity, no bruising, and no hematoma. Anotone, no overriding prostate and no bony prominence. Okay, now we also do assessment in disability. In disability, we look for the GCS patient, which is Mr. K have eye 4, verbal 4, and motor 5. Overall is 13/15, and Mr. K is respond to verbal. And then we do expose, which is we remove all inner chill and look for any obvious injury. And we find that Mr. K no long bone injury. Okay, after we expose, we warming patient to avoid hypothermia, and we put blanket to Mr. K. Okay, that's our investigation. That's our assessment. Now I want to share with you some investigation that we do to Mr. K. Firstly, we do focused abdominal sonography for trauma scan, which is we call as fast scan. Okay, then and a result is negative. We do chest radiography, chest X-ray, which is mediastinal shift to the right side, and vesical pleural edge was seen very thin and sharp white line. Lung collapse on left side. Okay, here are the X-ray. I show you for you X-ray, and if you see the lung at the left side become smaller because it's collapsed and it's content of air. Okay, after that we do hand X-ray because Mr. K said that he unable to move the right finger. Hand it still can move hand, but it cannot move his finger. And we find that no fractures seen, only laceration wound over right hand. Okay, pelvic X-ray show no abnormalities detected. We also do CT brain for Mr. K, which is we find no intracranial bleed or ICB. Okay, we also do urinary catheterization incision, which is we found no hematuria, just clear urine with 100 cc. Okay, there are a few blood tests that we do to Mr. K. Firstly, full blood count or known as FBC, and we find that hemoglobin Mr. K is 60.1. Okay, hemoglobins are very important in trauma case to look for any internal injury. Okay, and then we do for arterial blood gases, or we known as ABG, and no abnormalities detected. Here are the full blood count for Mr. K. Okay, no abdominal, just normal. Okay, we look at the HB is 60.1 in the normal range for male, which is normal range hemoglobin for male 13 until 17. Okay, now I want to discuss with you some management in emergency department for Mr. K. There are a few management that we do to help Mr. K. Okay, firstly, we maintain the airway, which is maintain of airway and circulation is the intermediate assessment and stabilize in patient trauma. For Mr. K, we give 15 liter oxygen with high flow mask. Okay, to increase the oxygen from 89 to 55. Okay, we give 50 liter oxygen. Okay, and then we do fluid resuscitation, which is insert 2 large bore intravenous catheter, and the branula we inserted is 40 G until 60 G only. Intravenous fluid therapy with the crystallite be initiated, which are normal line. And then we keep monitoring vital signs. Observe what's performance on patient blood pressure, pulse rate, and body temperature. Okay, then we monitor urine output. Urinary output is used to monitor renal output and should be maintained. Monitor urine color for early detection of hematuria. And then, because Mr. K have a lot of abrasion wound and and also have laceration wound, we give IM-ATT 0.0 to prevent tetanus infection. And then for pain management, we give analgesic to Mr. K, which is we give IV fentanyl 0.1 to reduce pain. We also do flavin dressing over the abrasion wound to help to prevent infection. And then we also do toilet and suture, or we known as TNS, over laceration wound at the right hand. It will help to stop bleeding. And the important is we do chest tube insertion. Okay, for your information, in pneumothorax case, chest tube insertion in the pleural space to remove air. The collapsed lump will re-inflate as the pressure of the lung decrease. Okay, how to do chest tube insertion? Chest tube. Okay, a small incision about 2 cm length was made at the safety triangle, which is defined as the area bounded anterior bilateral border of pectoral majors. Okay, I repeat, we do a safety triangle, which is defined as an area bounded anterior bilateral border of pectoralis major muscle, posterior bilateral border of latissimus dorsi muscle, and axillary apex at 5 intercostal space. Okay, if you can see now, this is a picture where the place we call safety triangle. And when doing chest tube, okay, we must remember that patient in supine position, which is hand is placed behind the head to expose safety triangle area. Okay, it will help to find where is the safety triangle in area. Okay, and then chest tube size 32 insert and attach to a special one-way drainage system that allow air to flow out only one way. Okay, it prevent the air for following back into the pleural cavity. Okay, it also known as underwater seal, which is used to monitor the fluctuating of fluid level in the tubing. Okay, the most important management that we do for Mr. K is chest X-ray post chest tube insertion. Why is it important? Because chest X-ray post chest tube insertion can confirm placement of the chest tube to make sure it is not malpositioned. Okay, in Mr. K case, we diagnose him as a alleged motor vehicle accident with cerebral concussion and left pneumothorax. In this case, there are a few differential diagnoses, which is such as first, lung contusion, second, hemothorax, third, hemopneumothorax, fourth, rib fracture, and 5, diaphragmatic injury. Okay, before I end, okay, I want to conclude that trauma is the most common cause of chest injury, including pneumothorax. Okay, pneumothorax is defined as presence of air in the pleural space between the lung and chest wall. Okay, what we do is the most important thing, immediate action of chest tube insertion was carried out to treat the patient and thus prevent future complications such as tension pneumothorax. Okay, for case Mr. K, okay, what we do are chest tube, and now lastly, patient Mr. K was subsequently admitted to surgical ward and future management handled by surgical team. Okay, what I see in Mr. K case, we do immediately chest tube to help him. With chest tube, it can balance the air pressure in his lung. Okay, that's all from me. Thank you for lending me your ears. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih.